and the instrument reads the CBC with differential as having a higher white blood cell count than it should, then that means that patient could be misdiagnosed as having maybe an infection when maybe they don't actually have an infection. So we need to ensure that you're just following proper collection technique, make sure that your blood's not flowing too slowly into the tube, and then most importantly, make sure that that tube is getting mixed right away with the additive. And then this is how normal non-clotted blood should look. All the little pink ones are your red blood cells, and then you see the little tiny dots, those are your platelets, and then the nucleated ones are your white blood cells. So what do you do to process your tube for your CBC with differential? So you must have 2 milliliters of blood. So if you think your lavender top tube is a 4 ml tube, so your tube should be half full in order to do a CBC with differential. And then it should be stored in the refrigerator at 2 to 8 degrees Celsius. So that lavender top tube for your CBC with differential is only stable for 24 hours. So why is that such a short time? That's because over time the integrity of the white blood cell starts to disintegrate and those white blood cells start dying. So then if your white blood cells are dying and are little fragments now, then the instrument's not going to pick them up and identify them as white blood cells, which changes your results. Also, the red blood cells start to swell, and then your indices start to change. So your MPV and your MCV increase with time. The refrigeration does help maintain the integrity of your white blood cells so the instrument can pick them up, but it only lasts for 24 hours. Now, if you do have any testing that requires EDTA plasma, you'll have your lavender tube, and then you would centrifuge your lavender tube and then pull off the cell-free plasma and place it into a clean labeled aliquot tube and transport according to the test directory. Now we talk about SSTs and PSTs and red top tubes, but what's really the difference between these tubes? Your SST is your serum separator tube, your PST is your plasma separator tube, and your red top is a serum tube, but it has no gel barrier. So what's the difference between plasma and serum? Serum does not contain the clotting factors, while plasma does contain the clotting factors. So if we are doing a PST, that's the light green top tube, we know that the PST has lithium heparin as the additive inside of the tube. So heparin causes blood to not clot. So after you draw your PST, you need to just make sure that your tube gets mixed with the additive inside of the tube. And then we know that that tube's not going to clot, so it's ready to spin. And I purposely put this picture upside down of the PST because when you turn that tube upside down, your blood should just flow freely and flow to the bottom. It shouldn't stick at the bottom of the tube as a clot. So your PST, once it's been drawn and mixed, can go in the centrifuge and get spun down for 15 minutes. If that tube does not get mixed right away, it could cause issues like microclots and lead to fibrin formation, which can cause instrument downtime and cause issues. So once your PST has been separated, your tube has the different layers. This top layer is the plasma, and then this layer right here is the gel separator, and then at the bottom we have our cell solids. So that tube is now ready for testing, and then you can just refer to the test directory for how it needs to be transported and stored to get to the lab for testing. So if you have a serum tube, what do you need to do with this tube to get it ready to go to the lab? So your serum tube, we said that it does not have the clotting factors in it. So that means that that tube needs to fully clot. So your SST, your gold top tube, and your red top tube actually have a clot activator sprayed inside of the tube. This clot activator does not make the blood clot faster, it only enables it to clot. So a person that has no clotting abnormalities, their blood should clot in approximately 20 to 30 minutes. If a person that does have any coagulopathies, or maybe if they're on some anticoagulant therapy, their blood may take longer to clot. Every person's physiology is slightly different, so it kind of depends on the person. And then one way to tell if your tube is clotted well enough, because if you're like, well, I know my patient's on anticoagulant therapy, how do I know if it's ready? If you turn your tube upside down and you see that there's a big thick clot and it's not flowing at all, then you know that it's fully clotted after that 20 minutes. So what happens over time to some of the chemistry analytes on your serum tube when it's going to be tested? So most analytes are going to stay the same for the first hour. However, over time, the analytes are going to change the longer the serum is on whole blood. I like to think of it like this. Your red blood cells, they're still alive in that tube, and so they're trying to stay alive, and they're going to eat up the glucose that's sitting in the serum to try to stay alive. So over time, your glucose is going to drop. And they've actually done studies, and they say that when serum stays in contact with cells, the glucose concentration decreases at a rate of 5 to 10 milligrams per deciliter per hour. So I did my own little study to see how glucose changes over time. So I drew several tubes all at once, and then I let the tube sit for 5 minutes, for 30 minutes, 1 hour, 2 hours, 4 hours, and 6 hours. So for the first hour, that number kind of stays right in the upper 90s. However, after that first hour, it starts dropping. So after that tube has not been spun for 6 hours, there's a 30% change. So if there's a patient that does have a fasting glucose that's being done, and let's say tube that their blood sugar should be 130. So greater than 125 by the American Diabetes Association is considered, for fasting glucose, is considered diabetic. And then the tube sits for 4 hours unspun. So that tube could potentially look like it's low 100 and within normal range, and then that could be missed. So this is why it's important to make sure that how long your tubes are sitting and the time that it is between when you're going to get that tube spun. Also, so those red blood cells, they're trying to stay alive by eating that glucose, but some of them are dying. And so when the red blood cells are dying, they're bursting open and they're leaking their intracellular contents. So the intracellular contents are naturally higher in potassium. And so if those red blood cells are bursting open, then that could potentially spike the potassium the longer the serum sits on whole blood. If you do have an unspun tube, and if you looked at the test record and you see that it should be refrigerated, you shouldn't refrigerate the tube if it's unspun. So what can happen is when it gets refrigerated, your analytes are going to change because the refrigeration is going to cause those red blood cells in the SST to burst open, and it could possibly increase the potassium level in those tubes. So that's why it's important to make sure that you refrigerate your SST tubes after they've been spun. So how long do we need to wait before we centrifuge? Your centrifuge, for centrifuging your SSTs and your red top tubes, they should be spun down after that tube has sat for 20 to 30 minutes, but before 2 hours have passed. And then you want to make sure that you're centrifuging. Your tabletop centrifuges, they usually are between 3,200 and 3,500 RPMs, and then they should spin for 15 minutes. So if you spin your tube down after collection between 20 minutes to 2 hours, that's going to provide results that are most representative of the patient's physiological status. If that tube has sat for 2 hours unspun though, those results have changed, and we actually recommend recollection. So everything in life needs to be in moderation and in balance. So if your centrifuge is not spinning long enough, this can cause issues. If the centrifuge isn't spinning for that 15 minutes, then you might not have good separation. So then that means that the serum is still in contact with the cells, which can change those results. So if you do have a tube that after you take it out of the centrifuge, you'll notice that there's still blood sitting on top of the gel. Then what you need to do is you take a pipette, pull the serum off, and put it into a clean labeled aliquot tube. You do not recentrifuge that SST tube or PST tube. And then after you have that tube, you spin it down that maybe had some blood in it, then you take that off and put it in another tube. And on the other side of that, we don't want to spin our specimens too long. So if the centrifuge is running and running and running, if it's spinning for more than 20 minutes, then this is it's kind of like squeezing the cells on the bottom of the tube, and you know the intracellular fluid has different chemistries than the serum, and so then that's leaching out some of the cellular contents. So then that can also increase potassium. And then if anybody's ever taken their tubes out of the centrifuge and they feel really, really warm, because maybe the centrifuge was just going and going, that can cause the samples to just become really, really warm, and it can almost cook the samples. So then that changes the chemistries also. So if you do have your red top serum tubes, you are, we said this is a serum tube. It's a lot like the SST, but it doesn't have a gel barrier. So you're going to let this tube clot the same as your SST for that 20 to 30 minutes, but before 2 hours. And then you're going to centrifuge it for 15 minutes. And then there's no gel separator in it, so this tube has to be aliquoted. So if you just put that tube in the refrigerator to send to the lab, then the cell solids and the serum are just going to mix back together. So to aliquot this, you'll take your pipette, squeeze your pipette, put it into the serum above the cells, pipette up your serum, place into a clean labeled aliquot tube. So after your SST is separated, we have the serum on top, and then we have our gel in the middle, and then at the bottom we have our red blood cells and cell solids. So it's always a good idea to make sure that you inspect your tubes and make sure that you have good separation after you take them out of the centrifuge. Your serum should be kind of a nice yellowish color. If your serum ever looks kind of pink tinged, or even red, then that is an indication of hemolysis. And if your sample is hemolyzed, we do recommend recollection. So hemolysis is when your red blood cells rupture, and so then they release their hemoglobin and other analytes into the serum. So this causes falsely elevated results for some analytes and falsely decreased results for other analytes. Even though we most commonly see hemolysis on the SST tubes, hemolysis actually affects all aspects of testing. So your hematology, your CBCs are affected, and also coagulation is also affected by hemolysis. Some of the things that can result is a whole blood analysis is that hemolysis causes a decreased red blood cell count, decreased hematocrit, increased MCH, and increased hemoglobin. And then on your chemistry tubes or your SSTs, erroneous results occur for sodium, potassium, chloride, glucose, BUN, creatinine, and ionized calcium. So what causes hemolysis? One of the things that causes hemolysis is your technique with how you are collecting blood. So make sure that you're following proper blood collection technique. Also, improper handling, processing, and or transportation can cause hemolysis. Like when we talked about how the centrifuge running too long can cook the sample, that could actually cause those red blood cells to burst open and cause hemolysis, like extreme temperatures. And then also your choice in blood collection equipment can cause hemolysis. So if you're using too small of a gauge of needle, or if you're transferring blood from the syringe to the tube, and then if there's improper blood to additive ratio. So after you've collected your blood and you've processed it, then you just want to make sure that you transport your specimen to the lab according to the storage requirements. So you want to check the lab website for your storage and how it needs to be transported, and then make sure that you're placing all specimens for one patient in one bag. So all of your refrigerated specimens, if you have a CBC, your lavender, and your centrifuged SST will go into one bag, and that one person has one bag. So you're not sending multiple patients in one bag. And then if you do have any specimens that are at alternate temperatures, you can go ahead and place that alternate temperature specimen. Like if you have a blue top tube that needs to be room temp, you can place that in a separate bag with a copy of the requisition, and make sure you write copy at the top of the requisition, and then make sure that you're placing all specimens in the courier pickup bins at the same time, so that the whole person goes to lab at the same time. So then your specimen's ready for transport to the lab and ready to be tested. So, in conclusion, today we've reviewed and talked about specimen processing and how the different factors affect testing. We've touched on the lavender tubes and what you need to do for whole blood testing, what you need to do if you have plasma testing on a lavender tube, the difference between SSTs and PSTs and red top tubes, and what needs to be done and how different factors affect testing on those different tubes. Does anybody have any questions?